Yes, sir.
Yes, as we are having the tea break afternoon, let's listen to Ritu ma'am, our president, who is of course today, right from the morning, madam is attending uninterrupted, either on or off the screen. So let's listen to madam and her summary so that you can get also refreshed by inputs from Ritu Sani ma'am. Yes, ma'am.
Good evening, sir, and good evening, all the participants. And uh, I think we all have enjoyed the full session from morning onwards because I don't have words to express that what the sir was as a part of the clinician, what is our duty, which sir has started the day with that particular session, because whenever we learn or we attend any workshop, these things which sir has mentioned today, nobody never explain these things. Because if you are going to attend any workshop related to the elbow, so the person will only concentrate on that particular part, that how you give the manual therapy for the elbow, but nobody will explain these things which sir has told, that how we start our evaluation assessment as the part of the clinician, as we see how we differentiate between the patient symptoms with the articular, myofascial, and the neural, because this differentiation is very much needed as a part of clinician. How we differentiate, if how that either if the patient is not allowing to touch that particular area where they are having a pain, so how we differentiate if the pain, according to the pain scale, that either the under the 5 or after the above the 5, so how we will take that patient in our hand, that by giving that the proper evaluation in that differentiation of articular, that which sir has started, that first you have it should be very much clear that what kind of the problem in the, like if we are talking about the elbow, in what kind of the injury or what kind of the history of that particular uh, trauma in that particular area, so that we can decide with the articular dysfunction how either the distraction or the we can do that distraction, and we can give that compression to that particular joint, so that we can understand the mechanism. And if that particular area where the patient is having a pain out of 7 8, so that time how we correlate with the contralateral side of that particular upper limb, so that is also very important, which sir has explained how, because we normally we just check that the tenderness and we start our evaluation, but if there is a more tenderness and patient is not allowing, that time how we will tackle, which sir has explained today. And if we talk about the myofascial component, yes, the patient is in the pain, so that we know that how we can give the relieving factor. If the patient is having in the aggravating factor, so how we can give the contralateral side, or we can give the reciprocal inhibition. So first our duty is to just relieve the pain, then we can start our treatment. And same with the neural component, loading versus the offloading, sir has, I think I will say that that full upper limb neurodynamic testing itself sir has explained for all the nerve which are the contributing in the upper limb, with the brachial plexus to median, radial, and ulnar nerve with their components sir has explained, with the loading versus the offloading, that sir has explained. And in this also, that how we can go towards that particular area if the patient is having in the both the sides, the patient is having a pain. So understanding of the autonomic nervous system with the dysautonomia, how that also we can treat with the sympathetic or the slum test. So that is also very important part of our understanding, for that not only for the elbow, these things which sir has added, it is for all over the part of our body. So in this also, and also again that with the elbow we covered the neuromanual therapy, we covered the physical test evaluation assessment with the physical testing, we have covered the differential diagnosis for the elbow also. And again we reached that particular topic of AMPT, where pain based mechanism also sir has highlighted, that if the patient is having a pain, so how we can treat through the brain, which sir has explained very beautifully. Because we know that the main fibers that what are contributing in the pain as a part of the nociception or as the part of the nociplasticity, autonomic nervous system. So these all are the part of our pain based mechanism, where we start with the central sensitization, cognitive affective, nociplastic, nociception, and autonomic nervous system. So that also sir has added fully, that where you can give the treatment related to the autonomic nervous system. And again, one more thing which sir has added, that how parasympathetic versus sympathetic nervous system, how we can relate with the, if the patient is having a symptom related to the neural component, so how we can go towards the vagus nerve, which is also related to the parasympathetic nervous system. So that also sir has simultaneously added in between, that if you are not getting proper relief, so then that time you can also address the vagus nerve to activate the parasympathetic nervous system. So this is also, I will say that the full, there are not only the session, this session is not for the elbow, this session is covered with the 5 or 6 topics in a very short time sir has explained, and he has not left anything in that particular topic. It is also very important thing which I want to highlight, that he has added all, if he was explaining NMT, neuromanual therapy, so he added all these things with the practice also, that how you can differentiate by adding the component for that particular. If he added the dysautonomia, so he explained the sympathetic versus parasympathetic also. If he added the pain based mechanism, so he added all the things which are very much important for understanding this pain based mechanism. So this is the way AMPT always come with the upgraded sessions. So today's session, either it was for the elbow, but for treating the elbow, why it is important to as a whole see the patient, that is known as the patient centered approach, which sir always emphasize on these things. So I will say it was a very much knowledgeable session. Definitely we all have a this facility to take the video recordings, which we can see twice and thrice, so that in further session we can not give any burden to sir to repeat all these things. So we should be make one format, we should make one notes for clearance of all these things, that if you are going for the articular, what you will do, if you are going for the myofascial, what you will do, if you are going for the neural, what you will do. Then again sir has added the structural, regional, and functional interdependence. So if you are talking about the elbow, so what are the structures independence, articular, myofascial, neural, what are the regional interdependence, which one area to another area region sir has explained, like with the elbow, how you can influence the cervical spine also. In cervical spine itself, the kinetic and the kinematic of elbow, how we make the combination. Once the kinematic of cervical spine, where the movements of the joints we are adding, and kinetic of that particular area of elbow we are checking with that particular their action of that muscles. So that is also very much important, which sir has added also. So these things I will say it is very important. And again, by reaching the elbow, he went through the cervical spine also, because we see that the patient who are having a problem related to the cervical spine, so they are having some problem related to upper limb also, or they are having a upper limb problem, so they are having a connection with the cervical spine also, as per the myofascial component, their origin to insertion of the muscle, and as well as the neural component, which are sharing the brachial plexus and the cervical plexus to the upper limb from the cervical spine, which also sir has added, that how we can see for the neural loading of offloading of that particular cervical plexus, which is the median nerve and ulnar nerve and the radial nerve, how they are contributing in the elbow also, with the movement of that particular action of the elbow, where with the elbow flexion, with the extension, or with the internal and external rotation, which are the nerves which are contributing. So this is also important. And again, in the cervical spine, how beautifully sir has added that what are the midline structure, like the disc versus the spinous process, which we add with the extension flexion, lateral flexion, which we add with the facet joint, and as well as the movement, the rotation, where which we affect, we check for the foramen. So that is also sir has added in a very short detail, that how these structure can influence with the movement testing. So in that also, that sir has added the muscles which are with the first layer, second layer, and third layer, which sir was now explaining, that how we can understand the origin and insertion of that particular muscles which are attached with the cervical spine, and they are inserting into the either in the shoulder scapula. So their role of understanding with their action with the same side or opposite side rotation of that, how the trapezius versus the levator, that whenever you see in Instagram videos, people say that they are giving the stretching of the upper trapezius, but their movement testings are never be in a in appropriate action. So that is also important, which sir was highlighting, that the action of upper trapezius, that is with the lateral flexion to opposite the move rotation to the opposite sides. But if you are going to use as a reciprocal inhibition, so how you will give the shortening to that, which side you are standing in, that same side you are giving the stretching to that. So that is their reciprocal inhibition. But some people do, that is also very much wrong. And same with the levator scapulae, their rotation is the same side. So that differentiation between upper trapezius and levator scapulae is also very important whenever you are checking your cervical spine. And the influence of sir was explaining with the extension flexion, the influence of lateral flexion, how the patient is having a symptom changing, so that also is very much important. So these are, I think, all these things which sir has explained is really very much remarkable, and in a short period of time he has covered so many things. And after that, because there is nothing written that you are learning for this elbow, these things will be work for all the part of our body. So whatever, because if we know the anatomy of that elbow, that what we are going to check as part of the lateral or the medial, the lateral epicondyle, medial epicondyle, or posteriorly with the bursa, and also the patient who are having the fracture, supracondylar fracture. So that is also, so how these thing in this elbow, also the capsule and the ligament. So if we talk about the capsule and the ligament, so again we will reach towards that first session of the morning with the articular, the distraction and compression. So that also we check for the ligament and the capsule, that is also important. Or if we talk about the supination and the pronation also, extension and flexion also, so what are the muscles which are contributing in that particular movement, so that will be the part of our myofascial. And in that particular action, like with the elbow extension, we reach towards the median nerve, or for the internal rotation, the posterior cord, we check the radial nerve, and for the elbow flexion we check the ulnar nerve. So these things are also again correlated. So that's why sir has added the neuromanual therapy, because the all the three nerves are having the component of the structure of the elbow, and they are passing the elbow, so or to the shoulder, to the hand. So it means there is a correlation between that particular, because we have to be very very careful whenever we see that the patient is not getting the elbow flexion, or the full range of elbow flexion, or full range of elbow extension. So sometimes we only focus on the articular and myofascial, but we miss the assessment of the neural, the nerve. So when we are very much capable enough to understand the course of the nerve of these three nerves, then we can easily reach towards that particular area where we want to give the treatment. So I think it was really a very much fruitful session, and definitely we all have enjoyed this session also. And please, it's my request to you that make your own notes. Don't think that we can, because we all are very much busy in our own life, so we cannot remember everything. But if we will write down in one notebook, and if we are sitting free and we will open that notebook, definitely, because you are learning offline, whenever you will open that particular notebook, so you will remember today's session, that how the sir was explaining, how the hand placement was there. So these things will come in your mind. So definitely, I think you all are learning very well from sir. So good luck to all of you, and thank you to you, sir, for giving us such a wonderful knowledge in a very crisp manner, so that we can absorb in our brain. So because today's from morning onwards, I was focusing on the brain. So we have to be just taking up direction to our brain and understand all these things. And nothing is impossible in this life, because if empathy is there, everything is possible. If Senthil sir is there, everything is possible. He will not allow you to leave this room without understanding all these things. So please be careful in this thing, that you have to be just what I can say, like a good student. You have to be very much active in the session of UMPT. So good luck to all of you. Definitely, we will learn more and more from sir, because we are blessed with the best academy and with the best mentor. So good luck to you and thank you, sir. Yes, sir. Over to you, sir.
Yes, anything, madam, miss? Okay, cervical spine, influence of lateral flexion on rotation, flexion extension influence on the rotation, disc influence on nerve root, facet joint influence on nerve root. Yes. So within a region also, how pathomechanics can decode. Okay. Structural interdependence is articular myofascial neuron. But here, in a particular region, how we can see the interaction pathomechanically. And then we saw the muscles, of course, in different layers, and we were about to come to the lateral group. Okay. We'll continue with that and complete the muscles. What is the time now? 4:45? 4:50. Right? Yes. So we appreciate madam. Of course, today is Saturday, so she was trying to be fully with us. Tomorrow, she won't be with us. Okay. As usual. So we wish
I
madam also best of luck.
I will
Yes.
I will try my best for tomorrow's session after 12 or after 1. Definitely, I will try to come to join.
Okay. So we'll close
Yes, sir.
this and start a new one.
Yes, sir. Thank you, sir. Thank you, everyone.
Thank you.